Hello there, this is John speaking. This is the EMGM 106 Respiratory and Cardiac Arrest Review. I know you've already had your lectures, your anatomy, physiology lecture and all that, and I'm sure you've had your respiratory lecture as well. I just wanted to review some things about your respiratory system. If you think about it just in very simple terms, it's a series of contiguous tubes that start in the nose and mouth, so the oral or nasal pharyngeal areas, and it travels down to the back of the throat and down to the trachea and into the bronchial tubes. And as it gets further and further down this track, the tubes get smaller and smaller until they finally terminate at the alveoli where the gas actually exchanges. So if you're an EMT and you have a patient in front of you and they're saying, I'm having trouble breathing, I feel short of breath, I can't catch my breath, or having some kind of difficulty breathing, more than likely in most cases, those tubes in that system are somehow blocked, swollen, or some other way affected. So by just realizing that these tubes can be blocked by pus and mucus and water and blood and bullet holes and all kinds of things, it might help you get an idea of what's going on with the patient and maybe drive your treatment in the direction that you think it should go. So I know the esophagus is not a part of our airway, but it does rest right alongside of, right behind the trachea. This is an advanced airway course, and the advanced airway we're going to learn about is called the King Airway. And the King Airway works because it's actually placed in the esophagus alongside the trachea, and then the trachea is indirectly ventilated, and of course then the lungs expand and contract. So keep that in mind, that the King Airway winds up going into the esophagus and thereby indirectly ventilates the lungs. Now you've heard the terms, or you've seen the terms, ventilation versus respiration. Ventilation is the act of moving air in and out of your lungs, and respiration is the act of blood gases moving across a membrane at the alveolar level or at the cells, wherever it might be. So you have two patients here. So the one on the top here, this young lady, she's having an asthma attack. And you've already kind of learned, I'm sure, that when someone's having an asthma attack or they're having an allergic reaction, they get bronchospasms. So that means those tubes that we talked about have shrunk in size. They're narrower. It's harder to get air into her lungs. She calls because she can't breathe. She can't get air in. And her brainstem pretty quickly recognizes that she has an increase of carbon dioxide because she can't breathe out effectively. And because she can't breathe in effectively and exchange gases, she's also low on oxygen. So pretty quickly, the brainstem sends out messages to protect this person. One of the things that it does is it starts to incorporate more and more accessory muscles. It starts to make the intercostal muscles work harder and the diaphragm work harder and breathe faster to try to overcome this resistance in her airway. The problem with this is if this isn't resolved, eventually those muscles are going to fail. I mean, they're just skeletal muscles. If you run a marathon or a 10K, or you're doing wind sprints, or you're playing soccer or football, you're using skeletal muscles. And as you probably know from your own experiences, those muscles run out of energy. But in the case of this, if her muscles run out of energy and the muscles can no longer contract, then she'll stop breathing and she'll die. This is why we want to be very aggressive when treating these patients. High flow oxygen, even bag valve mask ventilations, help them with their medications, their MDI inhalers, and get them to advanced care as soon as possible. We don't want them to get so tired that they stop breathing. Now, the person down below, this person's been shot. This is a drug deal gone bad. Unfortunately, they were shot in the right upper quadrant of their abdomen, and the bullet went through their liver, and unfortunately, they're bleeding internally. So even though they have no bronchospasm, even though their lungs are totally clear and they're getting great tidal volume and there's great exchange of gases at the alveolar level, the problem is because of the blood loss, less and less red blood cells and blood pressure are getting back to the lungs. So less and less oxygen is being picked up and less carbon dioxide is being removed. So ultimately, the same thing is happening to this person as well. Eventually, this system's going to fail and they're going to die. So now, obviously, treatment for this is going to be a trauma center and a trauma surgeon. But in the meantime, keeping them warm, providing them with high flow oxygen, or preventing any further blood loss will all help this person get to the hospital and get the care they need. Now, airway assessments. You've learned about jaw thrust. You learned about head tilt, chin lift. They both work really, really well. And I know you've learned specifically that jaw thrust works well primarily for a trauma patient versus a medical patient. But realistically, you can use either of these uh, uh, airway maneuvers depending on the circumstances. It just varies on what it takes to open the airway. Don't be limited by this. We found that using a jaw thrust on a child or infant, even a medical child or infant patient who needs ventilations, is a lot more effective and efficient than doing the head tilt chin lift. Conversely, if you're in a mass casualty incident and there's multiple patients, you've got 20, 30, 40 patients in various degrees of injury or whatever has happened, and you have no other way of opening the airway, you can do a head tilt chin lift. So keep an open mind about this. I know you've been taught that very specifically, one's for medical and one's for trauma, but it really what it comes down to is if you can't get the airway open, they can't breathe. So you guys get the idea, hopefully. You've learned all about suctioning and all this. Don't be limited with your suctioning. Use it aggressively as necessary. I mean, you obviously follow the same rules, 15 seconds and on the way out and all that stuff you learned. Also, the French tip catheter, that curly thing at the bottom that looks like spaghetti, that's an amazing tool. If you already have an oral pharyngeal airway in place or you already have a nasal pharyngeal airway in the patient and you need to suction, you can suction right through those things. Those flexible catheters go right through or alongside the oral pharyngeal airway or down the nasal pharynx and all that. So that's there. You have those. So don't be limited to that rigid tip that you've been using in the lab. Again, oral airways, you know how to properly size and fit these. The biggest problem I see out in the field of these is people rush. If you think about it, if someone needs an oral pharyngeal airway, more than likely they're in pretty bad shape due to medical or trauma reasons. You have a tendency to try to rush, to hurry, to get things moving quickly because this person's life is in danger. But you grab the wrong size OPA, it's too big, it's too little, it actually causes more complications. So if you just take that 10 seconds or 5 seconds to pick out an airway, actually measure it to the person, and then insert it, it's actually much more effective, much more efficient, and there's not that issue with you inadvertently picking the wrong airway. I see this all the time out in the field. I'll go on a call and someone will have either way too small or way too big airway in a cardiac arrest patient or a trauma patient, and it doesn't work. It needs to be fixed. The same thing goes with the nasal pharyngeal airway. Size and fit the airway. You already know from the tip of the nose to the tragus of the ear. You want to lubricate that with some KY jelly. You don't want to put it in dry. And please, 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 please do not use the patient's blood or saliva to lubricate this. If you think about what's in saliva, there's bacteria and viruses and all kinds of crap. And if you lubricate that with the patient's own saliva and you shove it up their nose, all you're doing is giving them a massive sinus infection, which is something we don't want to do. So we carry KY packets on the ambulance, on the fire trucks. They should be in your airway bag. If they're not, then you need to put them in there because you've got them. I guarantee it. Now, when it comes to ventilate versus not ventilate, that's really going to be your decision. If the person is not breathing at all, or the breathing is really slow, or really, really fast and ineffective, it's pretty much a slam dunk. You're going to ventilate. The hard part really is that gray area where they seem to be breathing fine, but it's a little shallow. Their rate's okay. It's like 20 times a minute, but the chest isn't quite rising, as much as you'd like. And you're kind of concerned, well, should I do it? Shouldn't I do it? When in doubt, do it. As long as you're doing it correctly, with oxygen provided and good tight seal and all that, you can't really hurt the patient in most cases. So if the person is breathing effectively, this person has good tidal volume in a decent rate, but yet they're short on oxygen. Of course, you've already learned about the non-rebreather mask versus the cannula and all that. Predominantly, if you, in this, it's very subjective, and there's a lot of gray areas to this. But ultimately, if you have someone who's having cardiac issues, heart attack, or a stroke, you've already learned you want to titrate up to that 94 to 98% rate using a cannula. If they're below 90%, you're going to want to put them on a mask to try to do that. But pretty much everyone else, trauma patients, people in shock, people who have been shot, stabbed, hit by a car, someone in sepsis, someone's having serious breathing problems like an asthmatic, you're going to want to put them on high flow too. You want to get the saturations up if it's non-cardiac related or non-stroke related. Now, positive pressure ventilation. Again, you've already practiced this in the lab, but the big thing is mask sizing. What we have in our airway bags is we have 3 different size BVMs. We have an adult, a child, and an infant. And probably more than likely in your newborn kit, you have a neonate bag as well, in a separate bag for childbirthing. But you also have about 6 different size masks. The mask that comes with the adult size BVM is sometimes way too big for the adult. You think about it, you go to a convalescent home and there's a 89-year-old female, and she weighs about 90 pounds, and she's a little tiny person. And if you try to ventilate that lady with a normal adult size mask, you're going to get leakage, you're going to get blow by, you're not going to get good tight seal. So being a good EMT, you're going to recognize this and go, hey, I learned that bridge of the nose to the cleft of the chin thing. Let me go find a mask that will fit. Again, this is that 5 or 10 seconds of just extra time going, let me fit the mask to the person. Trust me, it works really, really, really well. And conversely, I've gone to high schools and junior high schools for kids who have been injured or sick. And I'm sure, you guys were in high school, obviously, and you more than likely saw the 220-pound 14-year-old. So you can kind of see where, don't think about, you're going to use an adult size BVM on that kid, and of course an adult size mask, because again, all you're doing is you're not thinking adult or pediatric, you're thinking what fits the person's body size and their facial dimensions. If you use it with an adjunct, an OPA or NPA, and you have good seal, double CE grip, single CE grip, and all that, you can, get good effective ventilations as long as the airway's patent. Now, something new that's come out starting July 1st of 2023. It's optional, and then in 2024, it's become mandatory in the County of San Diego. Every time that we use a bag valve mask, and every time we do mechanical ventilation on any patient, whether it's a cardiac arrest or whether it's a drowning patient or whatever it might be, we're going to wind up using a Peep valve. See that red thing right there? So normally where that red thing is, like the BVMs that are in the lab, that's the exhalation port. That's where the person breathes out of when you let go of the bag and the person exhales. This covers that port, and it restricts the amount of pressure that leaves the person's lungs. And so basically what this does is it keeps a little pressure in the lungs, and it keeps the alveoli in the lungs a little distended so they never fully collapse. So as you're breathing for this person, you're opening up the alveoli, you're getting oxygen into the alveoli, and then it's exchanging gases. Now, it does have some contraindications because of the positive pressure in the thorax that you're creating. It can also drop their blood pressure. So this is not for someone who's deeply in shock, someone whose blood pressure is less than 90 systolic. This would be a contraindication. Or if this person has a collapsed lung, again, you wouldn't want this to happen because that would just make the person go from a pneumothorax into a tension pneumothorax. But this is for the medical patient, the trauma patient who has a fairly decent blood pressure um, and who needs, that their lungs opened up. The asthmatic, the drowning patient, the congestive heart failure patient, the cardiac arrest patient. These are all excellent for this. I'm going to show you a little video here. So what you have here in this video is you have those are pig lungs, and the BVM is set up so it's going to ventilate the pig lungs. And this is a normal BVM without the PEEP valve. So I'm going to play it, and what you're going to see is as they're ventilating, what's going to happen is the lungs are going to expand and contract. They're going to basically fill and flatten completely out so they're completely empty. Now he's going to attach the PEEP valve to the end of the exhalation port right there. He just did it right there. And now he squeezes the bag, and you'll notice that when he does it, the lungs do not completely collapse. There's a little bit of pressure inside the lungs. It's keeping the alveoli open. And then when he releases the pressure, the lungs collapse. So these are really great devices, again, for people who have fluid in their lungs, asthma patients, drowning patients. And again, he'll show you again, completely flattened, and then put the PEEP valve back on, and you get that extra little inflation that stays in there. And it's very, very helpful, and it's going to be a great device for us. But I wanted to show this to you guys because you will be seeing it out in the field this year, starting July 1st. And it's optional until the first of next year, and then it's going to become mandatory. Everyone's going to have to carry these, so you'll be using them, I guarantee it. Moving on from respiratory, let's go to cardiac arrest management. So I know you learned the CPR skill, pushing on the chest and doing the 30 and 2 and the 15 and 2 and the depth and all that great stuff. But cardiac arrest management is a lot more than just pushing on their chest. And I think that we really kind of don't emphasize that enough here in our curriculum. So it's made up of a lot of different components. The first one is having a really strong team leader, having one person in charge who can delegate authority, who knows the strengths and weaknesses of their team, who's best at what and where to use them, knows how to change gears and all that. And good training and flexibility in your teamwork. So working together, on a regular basis, knowing, what roles you're supposed to play and who's in charge and all that. And you think about it as a team leader, if you go on a CPR and you arrive on scene, you're going to go through your process and sir, are you okay? And start compressions and attach the AED, whatever's appropriate. But as a good team leader, not only are you delegating authority and making sure everything is being done correctly, you're thinking 10 or 5 minutes ahead of your scenario. You're thinking, okay, in 5 minutes, I'm going to need to call the hospital and talk to the doctor on the radio. In 5 more minutes after that, I need a gurney, I need a backboard, I need an ambulance if I don't have an ambulance here. So you're always trying to keep 5 or 10 minutes ahead of the process. And that's really good leadership right there. And one thing I see out in the field, a lot of people, what they forget is they forget the survivors. Someone's dropped dead on the floor and the wife's there, the husband's there, the sister, brother, cousin, co-worker, whoever it might be, they're standing there going, what the heck? So don't forget the survivors. They're actually, for us, they're really patients. They need to be addressed. You need to, once you stabilize this patient, once you started your process and the cycles are continuing and all that, have somebody go over to them and explain what's going on, ask questions about the patient, uh, let them get at least involved in emotionally anyway with that. So don't forget your survivors. And think about it too. We're going to call the hospital at some point and make basically hospital contact. Uh, One thing about CPRs, which you might not have learned, is that not every single person in cardiac arrest gets transported. There are some people that just are not viable enough to transport to the hospital. They're not going to survive. So if you have any questions about that, you could call a base hospital and talk to a base hospital physician about this. And it's a bit of paperwork and all this great stuff, but ultimately, maybe call paramedics to scene, and the paramedics could pronounce the patient, or possibly if the paramedics are there, they could talk to the doctor. But at some point, this person might not be transported. So again, you as the team leader, in conjunction with the feedback from your team, you're going to determine, is this person viable? Talk to the family, ask the family about the person's preferences, what they would like, us to do for them, let them pass on, or give them every chance they have, those types of things. So a scenario right here. So you're working as a firefighter EMT. This gentleman walks into your fire station, knocks on the door. He's got just pains for the last couple of days. His saturation is 91% on room air. He's got this shortness of breath, and you hear some crackles in his lungs and all that. So you put him on some, cannula at 2 liters. You do your sample history and all that. And you kind of figure out this guy's had a couple of heart attacks. He takes aspirin and nitro. He's probably having another heart attack. So you treat him and all that great stuff. You reassess, and his discomfort gets worse and worse and worse. Patient becomes unresponsive on the sofa. You go, sir, 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 and there's no response. Trap squeeze, no response. Check for a pulse, a carotid pulse, there's no pulse. What do you do now? Well, of course, you get him on the floor and you start compressions. And then, of course, you start compressions is the highest priority. The next highest priority is going to be have someone attach the AED, because this is a witness to rest. In the meantime, someone's getting the BVM out, they're getting the OPA out, maybe the Peep valve, if you already have those, and you go through your cycles. Now remember, the wife drove him there, the wife's standing there. He walked in with his wife 10 minutes ago, and now he's dead. You think the wife's having some some issues here? So remember, don't forget the wife. Have the captain go over there and talk to the wife, explain what's going on. Ask the guy's name and his hospital preference and all that stuff. Uh, and again, with the survivors, we would not want his wife to drive herself to the hospital. So we did have to arrange for someone to drive her, or to come with the patient in the ambulance. I'd rather have someone drive her to the hospital, a family member, a police officer, maybe even one of the firefighters could drive, her to the hospital. We just don't want her driving because she's so upset. We don't want her crashing her car and all that. And again, you're thinking ahead of time. What resources do I need? Where am I going to go? And when should I start talking on the radio? So again, it's not just pushing on the chest. It's all these different components kind of put together in some kind of, logical sequence that makes these cardiac arrest management scenarios work out in the field. Now, there's all different kinds of reasons people go into cardiac arrest. The most common is more than likely a myocardial infarction or a heart attack, but blunt force trauma, so massive injuries to the chest, shootings, stabbings, penetrating trauma to the chest can all cause cardiac arrest. People can be electrocuted, they can drown, hypothermia. When it comes to electrocution, drowning, and hypothermia, these are medical conditions as well as an overdose, and these patients get the AED attached. When it comes to the blunt force trauma patients and the penetrating trauma patients, because of the amount of internal organ damage to the heart, the lungs, and other organs in the mediastinum, we don't attach the AED because there's really no reason, because there's nothing to shock. That those organs have been damaged. Whereas with the electrocution, drowning, hypothermia, and overdose, and of course, myocardial infarction, their organs are intact. They just, unfortunately, the heart's not functioning well at this time, so we can attach the AED. Treatment varies, again, by cause and presentation, how long they've been down for. If law enforcement is there, sometimes that plays a role in the process. DNRs are out there, as long as they're valid, you can honor them. There's obvious death in the patient, and of course, it's possible with online medical direction by a physician, you could, have them pronounced. There are some differences to the County of San Diego adult CPR standards. So the county says, and this has been going on for about 10 years or so, we don't follow American Heart Association standards. We follow, obviously the compressions are 100 to 120, which is the same, but our compressions are continuous, so you don't stop to ventilate. And we do one ventilation of every 10 compressions. So it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and on that 10th stroke, as you're lifting your hands up off the chest to allow that chest to recoil, your ventilation partner is going to squeeze the bag. So it's a 10-to-1 ratio is the most common, and it's been the standard for a number of years, like I said here. So you go work out in the field and you work with medics or fire department, they're going to be using a 10-to-1 ratio for adult standards. Remember, adults are anyone who is 15 years of age or older, according to the County of San Diego. Pediatrics, they follow both. So the county follows both American Heart, which is that 15-to-2 ratio, but we can also use the 10-to-1 ratio on anybody. So it says right in the protocol book, it says you can use a 10-to-1 ratio, and pretty much everyone does. That I've been working out in the field, for a long time, and no one uses 15-to-2. No one uses the 30-to-2. Everyone uses 10-to-1. With the only exception is the neonate. That's the newborn baby, and that's 3-to-1 ratio. But everyone else gets 10-to-1. Of course, they've, kind of trying to downsize us here. Let me show if I can play this for you. I can fire it is. So this is the Lucas device. So you can kind of see it's taking over for us, which is good and bad, I guess. The other one is, that's the auto pulse. So you might have those. You hook them up and it takes over your compressions and it gives proper depth and it's continuous at 100, I think it's 110 compressions per minute. That's what they're set at. And the depth is at 2.1, exactly 2.1 mechanically. They got some drawbacks, the battery packs and placement, and they slip out of position and all that, but they work pretty well. And we're done with our lecture. Hope this helped. See you in class.